So now let's get started. I'd like to welcome everyone to the Vasculitis Foundation webinar today. I'm Kathy Olewski, and I'm the host for the Vasculitis Foundation's educational webinar series. I'm also a patient living with MPA vasculitis. These webinars are part of the Vasculitis Foundation's commitment to patient education, and we would like to thank our sponsors, AstraZeneca, Amgen, and Novartis, for supporting these webinars. And today's webinar is about shingles. After we finish the webinar today, there will be a recorded version on the Vasculitis Foundation's YouTube channel, and everyone who registered today will receive an email with a link to it as soon as it becomes available. And before we get started today, I just want to go over a few details because this is a live webinar. So we have muted everyone except our guest speaker today. And in today's webinar, Dr. Cassandra Calabrese will educate us about the many aspects of shingles. And after her presentation, you'll have the opportunity to ask her questions. These questions can be asked by typing your questions into the Q&A box. I will begin today, however, with the polls, if that's okay. If we start with, we have a question for some of our people that are watching today, and we'd love to know what your thoughts are about shingles. So I'm going to launch that right now and let you have a look. If you'll see now, the question is, have you had shingles? So I'll give everybody a chance to find that information. Very good. It looks like most of you have had a chance to answer that. So I'm going to share it so that Dr. Calabrese can actually see what the results are. 1 second here. So the question was, have you had shingles? What do you think of those results, Dr. Calabrese?
So about a third of you have had shingles before. That's a good chunk of you. I thought it'd be helpful to open with that question to set the stage of the rest of our conversation.
That's great. And thank you, everybody, for participating in that. And now the part that I had left out is by introducing Dr. Calabrese. She's an assistant professor of medicine at Cleveland Clinic Lerner College of Medicine in the Department of Rheumatologic and Immunologic Disease and the Department of Infectious Disease at Cleveland Clinic. And thank you so much for being here, Dr. Calabrese. We appreciate your time today.
Thank you for having me. Thank you, Kathy.
And we would love it if you would share your screen and start educating us.
This rolling. Hopefully everyone can hear me okay.
Yes, we can.
One more thing. Okay. Let's see. So
you're not, it's perfect now. It looks great.
Okay.
Yeah.
Great. All right. So thank you for having me. I am a rheumatologist, and I also practice infectious disease and have very particular interest in infection prevention in patients who are immunocompromised, specifically from rheumatic diseases like vasculitis. And therefore, I'm very interested in immunizations and conversations surrounding immunizations and increasing vaccine uptake and addressing vaccine hesitancy. So I was very happy to be on here to talk to you guys about herpes zoster, also known as shingles, and the vaccine that prevents this infection. I want to go over a little bit of background. What is shingles and herpes zoster? I'll try and, for the most part, refer to it as herpes zoster or HZ, but know that that's interchangeable. Shingles is the same thing as herpes zoster. And symptoms, risk factors, treatment for this infection, and then how do we prevent it, specifically the vaccine. So this infection is caused by the virus, Varicella zoster virus. This is in the herpes virus, so that also includes HSV or herpes simplex virus that causes, cold sores amongst other things, as well as several other viruses. But VZV is the virus, and it has two different flavors. In childhood, you get the infection for the first time called a primary infection, and that's chickenpox. And for the most part, everyone's had chickenpox. If you were born before 1980, you've most definitely had chickenpox. If you were born after 1990, you probably were immunized against chickenpox, but that is an infection with zoster virus. It's very contagious. You breathe it in, it goes in your lymph nodes, throughout your body, it travels to your skin and makes, the rash we all know as chickenpox. And then that confers lifelong immunity, which means you can't get chickenpox again, but it can wake up later in life and cause herpes zoster or shingles. Chickenpox is very infectious. If you were in a household of 10 people that none of them had had chickenpox before, and one of them enters with chickenpox, almost 90% of them would probably get infected from that one person. After chickenpox, the virus goes back from the skin down the nerves and kind of lays dormant or asleep in the nerves. And then many risk factors later in life can make it wake up and cause this herpes zoster, which we'll talk about. This is a picture. If you've ever had shingles or herpes zoster, this is what it looks like. The number one risk factor for waking up that VZV and causing it to travel back down the nerves and cause this rash is age. Older age is the huge risk factor for getting shingles, as are other things, stress and immunosuppressive medications, of course, that we'll talk about. But this rash is very painful. Before the rash appears, we might notice a prodrome or kind of pre-symptoms of burning or itching or even numbness or tingling. These are fluid vesicles, if you can't tell from the picture, kind of like chickenpox, and they scab over in about 7 to 10 days. And then most patients, this pain is gone in 4 to 6 weeks. And some unlucky patients, this can last for a very long time, which we'll talk about, the pain. So the lifetime risk of herpes zoster is about 20% in the US, and that's across all age groups. If you look at people 85 and older, half of them will have had shingles at least once in their life, so very age dependent. And that incidence of shingles is increased twofold, sometimes more, depending on medication a patient with autoimmune rheumatic disease might be on, but a significant increase in patients with what we call autoimmune diseases or immune-mediated inflammatory diseases like vasculitis. All immunosuppression theoretically increases incidence of shingles in systemic steroids, so being prednisone, either a high dose or for a long time. A class of drugs called JAK inhibitors, of which the generic and brand names are listed here, and then being on combinations of immunosuppression. So if you're on, prednisone and rituximab, or, Cellcept and prednisone, or, variety of combinations, that combination also increases your incidence. And then add age onto that, and that further increases the risk. Post-herpetic neuralgia is what we call when pain lingers in that spot of the rash, even though the rash is completely gone. In lucky, if that happens, it lasts months. In the unlucky, that can last years, many years. And that can be very painful and very debilitating. Especially in immunocompromised persons, herpes zoster can also lead to nerve paralysis, in particular of the face, especially if the infection is on the face, head or neck. Motor weakness, it can affect the motor nerves. It can cause stroke. Having an episode of shingles is actually significantly associated with an increased risk of stroke, especially in the first month after shingles. Another reason to get vaccinated that we'll talk about. And then disseminated means that the infection spreads throughout your blood and the whole body, which is very bad and very rare, but increased in people who are immunocompromised. If you get shingles, there is a treatment, best if started sooner rather than later. These are antivirals, one's called valacyclovir or Valtrex, and the other's acyclovir. They're recommended for anyone who's immunocompromised. They're also recommended if you're healthy and 50 and older. Recommended for anyone who has herpes zoster around the eye, or if you're having, a really bad episode and new vesicles keep appearing, or if you're having any sort of complication from shingles, then you should receive a course. Most of these are about a week long of antiviral. Valacyclovir is 3 times a day, acyclovir is 5 times a day. This can shorten the duration of and new vesicle formation and improve healing. It can help with pain, but they're not, 100% effective in making this. So prevention is preferable to treatment, and treatment does not prevent certain complications, including that neuralgia that we talked about. So immunosuppression increases the risk of getting shingles and its complications. So people who are immunocompromised are at increased risk for getting kind of those more severe forms I mentioned a couple slides ago, including post-herpetic neuralgia. That painful state can make the disease more severe. So if you've ever had shingles, you know it kind of occurs in these stripes as depicted here on the right. These are called dermatomes. These are kind of the levels that match up with the nerves coming out of your spine and feeding sensation to your skin. So you will get shingles in just one stripe of this color here, a green stripe or a blue stripe. And very rarely will there be vesicles in multiple layers. That's called a dermatome. If you are very sick and have disseminated shingles, it might spread even across the whole body. So, as I mentioned, prevention with a vaccine is preferable to treatment. And we fortunately have a highly effective vaccine called the Recombinant Zoster vaccine, trade name Shingrix. This is a non-live vaccine, contrary to the former shingles vaccine, which many people on this call may have gotten in the past. That was a live Varicella Zoster vaccine and called Zostavax, and that fell by the wayside probably 3 years ago now. We actually don't use that in this country anymore. Every existing dose that has expired, and this is the only available shingles vaccine now. This is pertinent for the United States and other parts of the world. Many countries, even in Europe, only have access to the live vaccine. But here we have Shingrix. It has a very potent adjuvant in the vaccine, which is something that stimulates the immune system to make a great response to protect you against this virus. In 2017, this was when this was first approved, and based on 2 big studies called Zoe 50 for the age of participants in that study, and Zoe 70 for the age in that study, and were published in the New England Journal. They were not inclusive in immunocompromised persons, which is usually the case in a big clinical trial of a new vaccine, but did show that this vaccine is over 90% effective. That is an excellent vaccine effectiveness at preventing shingles. And at present, our follow-up data is over 7 years. So that is sustained effectiveness. Even in people that were 80, 90 years old, this very, very favorable vaccine. In the course of us having this vaccine available to us, which has been 7 years now, there was some concern about use in people with autoimmune or immune-mediated diseases. Like, could this flare your underlying, vasculitis, for example? Will it work? And those are important questions that we'll touch upon in a moment. So currently, the vaccine is now recommended for any immunocompromised adult. This was updated in the guide 2 years ago now. So if you're 18 or older and are immunocompromised for any reason or soon to be immunocompromised, you should get a shingles vaccine. And then it's also recommended for any healthy person 50 and up, no matter what kind of health problems you've got going on or not going on. Because of that potent, what I called adjuvant, which is what revs up your immune system to make the vaccine work really well, it can also cause some side effects that fortunately are very transient if they happen at all. And this is called reactogenicity. This is your immune system doing what it's supposed to do, but might be a little bit unpleasant. We call that local reactogenicity, which would be like arm redness, pain, or swelling, and then systemic reactogenicity, which many of you probably noticed after the COVID vaccine, for example, the mRNA vaccines, just feeling icky, fluey, fevers, achy, very transient, a day, or 2 tops, and that could happen. I think it's important to warn patients about this. We tell patients not to get the day before, if you're going to your daughter's wedding or your own wedding. This day before that is not a good time to get this vaccine in case you get. So any side effect, which pain, fever, headache, happened in about 70% of people, and that ranges from mild to 1 in 10 reported a systemic reactogenicity symptom. That was significant enough to keep them from work that day. So that's 10% of people, which sounds like a lot, but isn't terrible. But it's important to be aware of before you get this vaccine. What also is important to know is if you have one of these side effects, these transient side effects after your first vaccine, which I've not mentioned, this is a 2-shot series given 2 to 6 months apart. Having a reaction after the first one does not predict you'll have one after the second one, and vice versa, which is great. So what does the literature show? Sorry for all these boxes popping up. Hopefully you can still hear me. This vaccine has, since its approval, been looked at in smaller studies, but reassuring studies of patients with cancer, transplants, bone marrow transplants, HIV, and have shown it's safe and effective. There are not a huge studies in patients with rheumatic diseases, but there are a handful, and they're all very reassuring that the incidence of triggering a flare of, say, rheumatoid arthritis or vasculitis is very low. The largest study to date, one of the largest studies to date, was actually done by us at the Cleveland Clinic, where we looked at a little over 350 of our immune-mediated inflammatory disease patients, including 50 with vasculitis, which is about a little less than 15% of the whole cohort, and looked at disease flare after receiving a vaccine, both doses. So looked at the 12 weeks after each dose. 15%, 16% of people had what was deemed to be a flare of their underlying disease after the vaccine, most after one or the other, and very few after both doses. And this was largely in the rheumatoid arthritis patients. I actually don't think that any flares occurred in the vasculitis group. But this is, I think, helpful to know and reassuring to know that we have no, concerns in recommending this vaccine to someone on immunosuppression, someone with an immune-mediated disease. And in our study, we had a very interesting observation, was that a third of the patients who had a flare, which again was mostly in rheumatoid arthritis patients, so like joint pain worsening after this vaccine, which I will say, it can be hard in these studies to separate. If you had a, Moderna or Pfizer vaccine, you might have noticed your joints hurt for a couple days after the vaccine. But what was felt to be a flare in a third of patients happened in relation to patient was getting like a prednisone taper or increase in their RA meds on the same day they got this vaccine. So what that tells us is if you're in a flare of your rheumatic disease, your vasculitis, that's probably not a good day to get this vaccine. Sorry about this. And I hope that makes sense. I'm happy to field questions about that. This is just some, a visual of patients being on steroids at the time of vaccine, like for a flare. You might wait till you're not having a flare and not on steroids for that to get the shingles vaccine. I want to wrap up before we open this up to questions, which is kind of more specifically addressing patient concerns and kind of how we would respond. And, I love to always ask a patient, to tell me more about why you haven't got this vaccine or that vaccine, so we can, talk about it. What have you heard? What are you worried about? So this is just a list of reasons I've heard, others have heard, frequently encountered, of why patients might not have had a shingles vaccine, ranging from I already had shingles, I already had chickenpox, I'd never had chickenpox, I already received the live vaccine, I don't need that vaccine, I don't trust that vaccine, it's not safe. Vaccines make me sick, or I heard my friend got that shingles vaccine and she felt awful, so, I don't want it. So kind of working through those patients who've already had shingles, this vaccine is recommended for everyone, regardless of whether you've had shingles. Believe it or not, and this is a very common misconception, you can get shingles more than once, you can get shingles more than twice. It's certainly not as common as getting it once, but being immunocompromised does increase your incidence of having it happen again. So if you've had shingles, that doesn't protect you from getting it again, and the vaccine, you'd still benefit from the vaccine. I've already been vaccinated against shingles with the live Zoster vaccine. So this vaccine is recommended by the CDC, regardless of whether you've had that live Zoster vaccine or not. That live vaccine, called Zostavax, was actually relatively ineffective at baseline. And then up to 5 years after you got it, your protection waned to, before, like as if you hadn't ever gotten the vaccine, as opposed to Shingrix, which is very durable, excellent protection against shingles. And so whether you've had shingles, whether you've had the old vaccine, this vaccine is still recommended for you. Vaccine's not safe. I already mentioned some of the safety data that are out there, both in rheumatic patients and other groups of immunocompromised persons, transplant cancer, et cetera, and is deemed to be very safe. There are no safety concerns. And then my friend got this vaccine and felt terrible afterwards. That's where that reactogenicity counseling comes in, where I think it's important to alert patients you might feel not great for a day. You might feel totally fine. And when your friend felt not great, or if you felt not great after, a COVID mRNA vaccine, that while it might have felt awful, isn't scary. It's your immune system doing its job. It's something that theoretically is supposed to happen, even though for as unpleasant it might be. So we call that reactogenicity counseling, just taking a moment to, set expectations and, let patients know that this could happen, and that it's okay and it will go away. I think that's all I wanted to add right now. I think we'll probably have some discussion and some questions and conversation we can have about shingles, the vaccine, or anything else you guys want to talk about. I'm going to stop sharing my screen maybe so that I can see if there's questions, or Kathy,
Yes, that would be great. As soon as you stop sharing your screen, we do have a few questions, and I would love to let you have them in just a second. I'll give you a minute to get where you're comfortable there.
Okay, yeah. Are you going to read them to me?
I am.
Great.
We still see your screen though.
Oh, you want me to just stop sharing?
Yeah,
okay,
stop sharing.
Perfect.
Now we can see you. That's great.
Okay.
One of the first questions that came up, I saw reference to it in your presentation, but I did want to ask you, after you get the first 2 vaccines, the way you're supposed to, you said 2 to 6 months apart.
Mm-hmm.
I think it said its efficacy is about 7 years. Do we get it again at some point?
That's a great question. The efficacy is longer than 7 years. This is just the follow-up data from the initial trial, and they keep reassessing this every year. So next year will be 8 years and 9 years and 10 years. But it is felt that protection is very durable even beyond that. And there is no recommendation to get the series over again later in life. And I will say the 2 to 6 month window is what's recommended. However, if you get the vaccine and come 8, 9, or 10 months, you forgot or happened, you don't have to restart the series again, even up to a year. And honestly, probably after a year, you can just get the second one late. They actually looked at that in the study, and it was pretty comparable effectiveness if you even got them a year apart. So you can still get the second one late.
That is great to know. I can't tell you how many people have asked that question and that is, I'm glad that you gave us that answer. Just a reminder to everybody, if you have a question for Dr. Calabrese, there is a Q&A box that you type your question into, and we will try to get to as many of them as we can today. The next question is, I'm on Rituxan regimen every 6 months. What is the optimal time to receive the vaccine? We kind of get that question frequently.
Yeah, that's a great question, especially because of all the immunosuppressing medications we use. Rituximab has the biggest kind of negative impact on vaccine effectiveness. But having said that, it doesn't have as big as a negative impact on effectiveness of the Shingrix. It's still good practice to time around your vaccine, but we have a lot of data on how rituximab negatively impacts flu vaccine and COVID vaccine and pneumonia vaccine. And we would recommend, if you're on 6 month cycle, to get vaccinated as long after your last dose as possible, and then at least 2 to 4 weeks before your next dose. So that would be 5 months. If it's not perfectly timed as such while you're on rituximab, that's okay for shingles vaccine purposes compared to other vaccines. I hope that makes sense.
Okay, great. We appreciate that answer. You did talk extensively about the possible reactions you can have to it, and you talked about reactogenicity counseling. And I guess that's when the doctor makes sure that what our expectations are, make sure we understand what could happen. But there is somebody that's asking, why did I get sick after each of the 2 Shingrix shots? It was like having the flu with each one.
I am sorry that happened to you. And you might have noticed in the study that I showed, that slide of the study that we did, about 8% of patients did feel not great after both shots. So you hopefully will feel great after both of them. 1 in 10 of you will not feel great after, a shot. And for most people, it's either after the first one or second. But for a small, unfortunate group, you will feel sick after both of them. And again, that's just your immune system revving up and making antibodies against the Varicella Zoster virus to prevent you from getting shingles. So while we tell you it's not common to feel sick after both of them, it will happen in a smaller proportion of people.
Well, thank you for that answer. And I'm sorry for those of you that have had the Shingrix vaccine and felt flu-like afterwards. However, as somebody who's had shingles twice, it is awful. The vaccine is on my list right now. And speaking of that, someone asked, after you have shingles, do you wait a certain amount of time to get Shingrix?
That's a great question. You, like from a safety standpoint, could get Shingrix anytime after you had shingles. That's not a problem. But from a practical standpoint, you probably have some natural immunity against getting shingles again for like a year. So I would tell people, get it next year, 6 months, 12 months, just as you probably don't need it right then, that moment. But if you wanted to get it, the 2 months after you had shingles, that's also fine. But we tell patients to wait a good 12 months.
Okay, thank you for that. And interesting question, is there a time frame once a shingles outbreak begins when you should get started on the acyclovir or the valcyclovir or another medicine in order to maximize effectiveness?
Yeah, that's a good question too. For any viral infection, whether you're talking about COVID or flu or shingles, the earlier the better for antiviral treatment. And that's because it's more effective if it's started early. However, you can start it at any time. It would never be too late to start it, but it would be more effective if you started in the first 48 hours, I would say would be.
Okay. Okay, great. Thank you. I have a question. When I had shingles, it started in the back of my head and it came like this. And I could see like the trails, fingers like of blisters. And it was interesting to me that is one of the ways they identified it as shingles because it was only on one side of my body. Could you tell us about that? I didn't understand that at first.
Yes, very good. That's a great question. So I showed that picture of the dermatome. So, there's your spine and there's what we call dorsal root ganglia, which are essentially like balls of nerves that go down each side of your spine. And the virus kind of sleeps dormant in those dorsal root ganglia, and you have one on each side. So it's only going to be in one or the other. Like I said, if you have disseminated zoster, which is very bad and could potentially happen in a very immunocompromised person where you'd have the blisters all over your body, it's otherwise going to be on just one side or the other, and also in that kind of localized stripe. And what you had is we call herpes zoster ophthalmicus, which is when it involves the nerves around your eye. That's actually what we call an ophthalmologic emergency. If you get shingles in your eye, you should go to the emergency room. If you're immunocompromised and get the blisters anywhere around your eye. But that's why it goes on one side or the other.
Okay, thank you. And since you brought that up about if it goes into your eye, I've heard that there are times when you have to see a different type of specialist because of wherever it's located. Are you supposed to see a dermatologist, or is there any other type of specialist you're supposed to see when you have shingles?
That's a very good question. Anyone on your care team should be able to, address and manage your shingles. Your rheumatologist, number one, and a family practitioner, that's well within their wheelhouse. Shingles doesn't require a dermatologist. The only special doctor it would require would be an eye doctor if it was in and around your eye. But otherwise, you don't need to see a dermatologist. You really don't need to see an infectious disease doctor. Shingles is pretty easily recognizable clinically, like looking and seeing the rash from that one picture, and your rheumatologist should be able to help you diagnose and treat that.
Okay, thanks. This next patient says I had shingles in 2019 and the shingles vaccine, 2 shots in 2022, and then I was diagnosed with shingles in 2024. Is that common?
Yeah, I'm sorry that happened to you. I wouldn't say that's common, but the vaccine isn't 100% effective. So there are going to be some people that still get shingles despite the vaccine. It should be very few. And we'd like to think it would, be of less severity than if you hadn't been vaccinated. But yes, for any vaccine, no vaccine is 100% effective. So there will always, unfortunately, be some people who get the infection despite being vaccinated.
Okay, thanks. And this person said, I had my 2 shingles vaccines in 2022. I was diagnosed this year with vasculitis. I had 2 infusions of Rituximab and they told me they worked, whatever that means, and no more infusions. So currently I'm on Imuran for the vasculitis. Am I still prone to shingles? But they had the vaccines in 2022.
That is great. You are, as protected as you can be, as evidenced by that last question. Very few people will still go on to get shingles even if they were vaccinated, but it's very few. And you did the best thing you could for yourself, which is get vaccinated before you started medications that would compromise vaccine effectiveness. So you're good and protected.
Okay, great. You're protected. That's good. We wondered, how does the occurrence of shingles break out by gender, or is there anything like?
It's a good question. There's a lot of interesting data on this. It is slightly increased in women, as is post-herpetic neuralgia. We don't know why that is either of those things, but it is slightly more common in women.
Okay, and I'm not sure we talked about this. Is it okay to take the shingles vaccine at the same time as the COVID and the flu vaccine?
That's a great question. It is fine to do that. You will see there are CDC recommendations to saying it's fine to get essentially any combination of vaccines together. And there are many practitioners who will tell you or encourage you to do that. And for most instances, I think that's fine, especially if you're talking about the flu and the COVID vaccine. This is just my practice. Tell patients not to get the shingles vaccine combined with another vaccine for the simple reason of it just increases your risk of feeling extra bad or having extra hurt arm, for a day or two. And if you don't have to get it on the same day and have the, luxury of being able to space them out in time, then I encourage you to do that. If you don't care and it'll, you have one day off and want to get it all done, that's also fine. It's safe and they're still effective.
Okay, thanks. One of the questions that came up that comes up often with vasculitis in general is also, can stress by itself cause shingles?
It can actually, unfortunately. Stress does a lot of great things to your immune system, but stress is one of the risk factors for shingles, regardless of age or immunosuppression. So another reason to lower stress when as able.
Well, we're all supposed to be on that plan anyway.
Yeah.
I've heard that the nerve pain from shingles can last a while even after the rash is gone. Is there anything we can do for this deep nerve pain?
Yeah, that's called post-herpetic neuralgia, and I'll tell you, not from personal experience, but just from being in this space, it can be very debilitating. This, even more than the pain of shingles, would be a driver to get vaccinated against shingles, so this doesn't happen to you. There are medicines to help control the symptoms, like medicines for nerve pain, if you've heard of gabapentin, Neurontin or Lyrica, but they're not 100% effective, and there's not a lot, there's really no role for prednisone or steroids in treating post-herpetic neuralgia, and there's no magic pill to make the pain go away, but some of those medicines can potentially be helpful.
Okay, and next one, is it true that it can be transmitted through touch or airborne exposure?
Yeah, this is a very infectious virus, as I mentioned earlier with chickenpox. But if you've had chickenpox before, you can't get chickenpox or shingles from being around someone with shingles. If someone who has never had chickenpox, or never been vaccinated against chickenpox or has no immunity, primary VZV infection, you could get chickenpox from being around someone's blisters. And out of caution in immunocompromised persons, was why we tell you to, not being around anyone with like open vesicles from shingles rash. But if you've had chickenpox before, you can't get shingles from someone's shingles, but you can get chickenpox from someone's shingles if you've never had it before.
Interesting.
Yeah.
That is good to know. There is one question. Is there any relationship between herpes zoster and herpes simplex, and can either or both cause a flare?
That's a great question. The short answer is, well, yes, they're related. They're in the same family, herpes virus family, along with the virus that causes mono, EBV, another virus that kind of plagues very immunocompromised people, cytomegalovirus or CMV, and then some other viruses. But yeah, they're very much related. They're in the same family. And the short answer is no, they don't trigger flares, but when you get an infection with a herpes virus, whether it's shingles or acute HSV outbreak, that's when your immune system is under a period of stress. So temporally related, potentially, if you were, stressed out, or, something's going on with your meds, or you're getting a prednisone taper or burst, as you suppose you could see, blisters in the setting of a flare, but that's not something that greatly concerns us. Like you get a HSV outbreak and then, the next week you get a vasculitis flare. That's not something we see or that's been reported, but that's a good question.
I just want to say to everybody, we are almost done with our questions. I have one more, but if you have a question, now's the time to put your question in the Q&A box so that we get it answered before we let Dr. Calabrese go today, because she's such a great resource. This is a weird question, but it kind of comes from my childhood when I was young. I'm one of 7 siblings. One of us got chickenpox, and my mom and the neighbors had a
Chickenpox party.
to give us all chickenpox and get it all done with at the same time. Crazy. I don't know if I could ever do that with my kids. Crazy, but is shingles, like, should we be, I would think not giving it to somebody would be the gift.
Yes, that you're exactly right. I'll tell you, your mom was not alone. That was common practice, at that time. That is frowned upon now. But I, certainly understand, you want to get chickenpox out of the way, and it's very contagious. So shingles, it's an interesting question, but in general, we're very much of the camp of, avoid these infections. And also, like I said, you can't get shingles from someone with shingles. So you would get chickenpox if you never had chickenpox and were around someone with shingles, which also is great. But yeah, stressing the immune system in that way, well, there's lots to read about and hear about. It's not great, even from, people that think, people, babies at daycare, they'll get sick and it's great for them and their immune system. It's actually not great for them. And we don't want to, openly expose babies to, COVID and flu just because other people have them. It's actually not a good way to build your immune system. There are other ways to do that. But so avoid, you can't get shingles from someone with shingles, but if you've never had chickenpox and are immunocompromised, you should stay away from someone with acute blisters of shingles.
Yes, so we're not going to spread that. I had shingles, as I said, twice. I
Don't willingly spread.
I did physically separate from my husband, who has never had chickenpox to his mother's knowledge.
There you go.
So my kids had chickenpox and we separated them from him. So, because I understand it's worse with adults to get it.
Yes, yes,
We did
exactly.
get a couple of more questions. One is I was the one that had shingles, the vaccine, and then I got shingles again this year. So should I get another vaccine is her question.
Fair question. I would say no. And just because there's no recommendation to revaccinate ever, you know, like your insurance probably wouldn't even pay for you to get vaccinated again. But having had that unfortunate shingles, despite being vaccinated, you have now boosted your immune system even more against getting shingles again. So I would hope that you would never get shingles again.
Yes, me too. This is somebody's confused from what we were just talking about.
And I'm sure it's confusing about the
No, she just says,
shingles thing.
she just says, can you repeat? If you had chickenpox, does this mean you can't get chickenpox or shingles from someone else? I'm not sure I understood correctly.
Yeah, no, I made it sound confusing. That's my fault. So I think the best way to look at it is chickenpox infection, which you usually get as a kid with spots like itchy all over your body. That is very contagious. You can't get chickenpox. Shingles is not contagious unless you've never had chickenpox. So vast majority of everybody, especially if you're born before 1980s, had chickenpox, and you would not have to worry about being around someone with shingles. But if you've never had chickenpox, then you can get chickenpox from someone with shingles. Do
Interesting.
you think
Okay.
that made it more clear?
I think that's clear, but
Confusing.
I do think that's clear. The next question is, are those who tend to get cold sores in the mouth and had chickenpox as a child, are they more prone to get shingles?
No, while those two viruses are in the same family, there's no association with having like recurrent HSV, the virus that causes cold sores, and getting shingles.
Okay. I do not see any other questions, and I think, let me just check some of the ones that we got in advance and
Very
make
good
sure.
questions.
Okay, what can cause shingles to become activated in the body after being quiet for so many years? I guess that means my interpretation is what can cause you to get it after your chickenpox was like when you were a child.
Yeah, so it's all those risk factors I mentioned with just age. You know, your immune system wanes over time. It's called immunosenescence, and just kind of loses control of keeping that virus asleep in nerves. And then things that contribute to that are stress and being immunocompromised.
Okay, I think you have answered every possible question we could think of on shingles, and I really appreciate the time that you gave us today and your being with us. I just want to say as a reminder to everybody that the webinar will be published on the Vasculitis Foundation's YouTube channel very soon. Everybody that's registered for today's webinar will receive a follow-up email with that link. And I did just want to take a minute before we completely close out today and tell you that just as patients, did you ever wonder what you could do to have an impact on important vasculitis research? Well, I can tell you that you can do something called join the VPPRN. I'm going to attempt to share my screen here. Here we go. And the VPPRN is an association that I'm a patient champion for. So I'm a big believer in it. And I encourage other patients to go join the VPPRN and complete their biannual forms. I think it takes like 10 minutes. But the research, your research is what drives your data is what drives research in vasculitis, and providing researchers with your information about you and your experience is key for advancing our knowledge of vasculitis. So I just wanted to share that one thing and then say that we are super happy to have had Dr. Calabrese. Oh, I lost my thank you slide. I'm so sorry.
Thanks for having me.
And to thank the Vasculitis Foundation for providing these educational webinars, and of course, our sponsors, Amgen, AstraZeneca, and Novartis. And thank you so much to everybody for being here today. And we look forward to seeing you in the next webinar.
Thank you. Bye, everyone.